Thank you. And I really have to say it's a privilege for me to be part of your radiology forum. Also, it's only online. Nevertheless, I really am proud of this. So what I will do is provide you an overview of the recent FIGO staging classification of cervical cancer. But before, as you told me, I will start with some information about our radiological system in Austria. Actually, Austria is a quite small country. We have a total of only 9 million inhabitants, and we are in the center of Europe, and we are considered a quite wealthy country. And we spend 11.5% of our gross content product for the healthcare system. That's quite a lot. It's a little bit less than 2% more than it's for the UK gross content product, but and similar to yours, our healthcare is really very well advanced, and it is notable that the healthcare system is primarily public. Private insurance is feasible, but it's optional and it's usually complementary. What's unique to our country is that there is a strict separation of intra and extramural medicine, and this is also true for radiology. We have a total of approximately 1,400 radiologists, and most of these radiologists are working in the hospitals. And you see the different hospitals spread all over our country. The most of these hospitals, these in Lilac, are quite small hospitals, whereas the orange ones are the larger ones, and most of these are the university hospitals of our country. It's also important to be aware that the number of extramural radiologists is quite small. These are about 150 offices, and usually it's one or only a few radiologists providing radiological service. So residency programs are done in all these hospitals. As the smaller ones will not provide often whole residency programs, it's necessary that the young radiologists rotate. So how long does it take to become a radiologist? In Austria, it's a total of 6 years. After School of Medicine, everybody starts with 9 months of common trunk of medicine, and then you go into your specialty. And for radiologists, it's a little bit more than 5 years. We have structured program where we start for 3 years with basics of radiology, and you have to obtain special numbers that are defined for each discipline in radiology. And in the second part, that's for 27 months, you can make rotations where you mostly you choose between 2 or 3 different areas in radiology. Everybody has to finish the residency program with a board examination, and then you have to decide if you go into a private practice or stay in a hospital, and the latter is what most people do. We do not have formal fellowships, but the larger, particularly the academical institution, live a specialization in radiology. So this slide shows you the age structure of the medical doctors in Austria. And what you can see is that for the advanced ages, there is clear a male predominance, but it's different in the middle ages. And now the percentage of female doctors in Austria is 47%. Notably, this has been increased for 10% in the last 10 years. As for the Austrian radiologists, we still have to catch up because here the percentage is only 35%. This guy you might know it's Konrad Wilhelm Röntgen, and I will not convince you that he is Austrian because he's a German. But there was a moment in history where this man, my country, Austria, and Great Britain were linked in history. And this was when Konrad Wilhelm Röntgen made the discovery of the X-rays. And after he had detected this, he sent reports of his detection and also prints. And this is the first image ever taken of his wife, Bertha, where you see the wedding ring. And he sent the findings of this discovery to various scientists. One among these was in Austria, in Vienna, and somehow this got leaked to the press, and it was immediately published in our major newspaper in January 1896. And this summary from this newspaper was then sent to the Daily Chronicle to London and the New York Sun one day afterwards. And this gave rise to dissemination of this discovery throughout the world. Actually, the renowned scientific journals, Science and Nature, were quite skeptical. They only mentioned it in editorials. But it was the British Medical Journal that championed this really renowned new discovery. And this was really the beginning of a very successful story, and it really changed medicine. So what we can say is it was German ingenuity, Austrian indiscrepancy, and British foresight to advance this technique. In my country, the most well-known and prestigious hospital, it's the University Hospital in Vienna. This is in the east of our country. My hospital is in the very west. And what you can see here is the whole area of our hospital from here to here. It takes like 600 meters to get from one end to the other. And here you see the Department of Radiology. We have approximately 800 doctors, a lot of beds, but there is some focus in oncology. I was also asked to tell a little bit about me. And actually, I have been the vice chair and chief of MRI for many years at our hospital. I started my residency program in Salzburg, but really pivotal for my career was the fellowship that I did at the University of California in San Francisco at that time when Professor Riesack was the head of radiology there. She really was a great inspiration for me, and I was so impressed by her love for radiology and her enthusiasm, and also how she mentored young radiologists. And I really tried to pass this on, and I have been a member of the Austrian American Foundation for now many, many years. I have been mentors of many people who started this program, and it was a program that originally was established to improve the skills of doctors of the former Eastern countries. Another milestone in my professional life was the membership in the European Society of Uroradiology subgroup female pelvic imaging and the ICIS. Why? Because in my country, the role of gynecological radiology is not that established. But here I really had the possibility to have a great network, to work with people sharing experience. And I have so many friends in these societies, and David Sala is one of these, and I really appreciate this. I have been for a couple of years also the Vice Dean for Students Affairs at our university, and I'm still the ombudsperson for good scientific practice. I'm the Vice President of the Salzburg Cancer Society, and I'm the recent president of the Austrian Röntgen Ray Society. this is notable because this is a society that has now been established more than 100 years ago, and it's the first time that a woman has become the president, and I'm quite proud of this. So, and last but not least, this is an image of me and my husband, and he's my husband for many, many years, and I have to say that he really supported me in any decision I made, and I'm very grateful for him. But now I come to the radiological aspect, and that's what I prefer to speak. So I have chosen the topic to provide you an overview of the recent modified FIGO staging classification of cervical cancer. Why did I do this? Because there really was a great discrepancy between clinical reality, where imaging was used for staging, and the FIGO staging classification. But the recent updated FIGO classification has acknowledged now the crucial role of imaging for treatment stratification. But before I go into detail, what should we know about cervical cancer in terms of figures? Actually, it's worldwide the second most common cancer. It ranks 6 in Europe, and also the cases for United Kingdom are not that high. It's still a formidable problem because the peak age of cervical cancer is quite young. And these results, number one, that fertility preservation plays an increasing and a very important role. And number two, it is the second most common cause of cancer death after breast cancers in a quite young woman population. So I want to make you familiar with two women who have squamous cancer of the cervix. They are in the typical age range. This female has a small tumor. It's less than 1 centimeter in size. There is no parametrial invasion, whereas here we have a tumor extending from the cervix to the upper vagina, and on the left side there is parametrial invasion. Why is this important? First, in terms of prognosis, but it's also important because in terms of treatment stratification, because in large tumors, and if the parametria are involved, then concomitant chemoradiation is the treatment of choice. In tumors that are early, it's usually radical surgery, and in some constellations, particularly if the size is small and the women are young, then fertility preservation can also be performed. So what does this mean for our two patients? In this patient with a small tumor and no parametrial invasion, both radical surgery and radical trachelectomy is a treatment option with the same prognostic criteria, whereas in the woman with a large tumor, it's only chemoradiation. What we also can see is that MRI clearly is well used, has been well used, and is able to clearly demonstrate the growth of the tumor that corresponds to the stage. This is stage 2B and this is stage 1B1. But the problem was that the preceding FIGO staging systems did not officially incorporate this information in the staging classification. Why? Because it was only a clinical staging system that was based on gynecological exam, cystoscopy, X-ray, and IVU. And as this was only clinical, no lymph node status was included, and this resulted in over as well as underestimation. And in acknowledgement of these clear shortcomings, the recent FIGO classification has been revised. And here the role of imaging now is a central one. This recent FIGO classification was done in 2018 and first published in 2019. I have also put here the alternative, the AGCC classification on the screen. Why? Because as these two are aligned, the very recent AGCC classification has also been changed, and you can read this online. But I will now focus on the FIGO staging classification, also because we know from one previous study that almost all gynecologists and pathologists from the United Kingdom use this FIGO staging classification. So what is new? In the revised FIGO staging classification, new is that the role of imaging is really central. We now can allocate the stage by using imaging or also by pathology. And if pathology is available, it supersedes the imaging findings. What's also new is that new stage is stage 1B. 3 subgroups are integrated, and this refers to fertility sparing techniques. And for prognostic and also treatment planning, the new stage 3C, that's the presence of lymph nodes, is also incorporated. So let us now go into the details, and this is a slide I have from Dr. Nogaret from Montpellier in France. And according to the classification of FIGO, stage 1 is confined to the cervix. And usually we do not see stage 1A on MRI, but what we can see is from stages 1B1. And MRI is well used to differentiate between these 3 subgroups, and it's the size that defines the subgroups 1B1, 1B2, and 1B3. Stage 2 refers to either extension to the upper vagina or the parametria. In stage 3, it's distal vagina, pelvic side wall, urethra, and importantly, the new class 3C with the lymph node involvement. And stage 4 refers either to local invasion of the bladder or the rectum or to the distal organs. So what you can see is that tumor size really is crucial. And that brings me to the question, how is tumor measured? And here we can only measure one diameter. It's no more necessary to provide the tumor size with 2 or more dimensions. FIGO only uses 1, and this should be the maximal tumor size. So let's go a little bit into detail of the various stages and start with stage 1B. 1B means that there is no parametrial invasion, and we see the parametria adjacent surrounding the cervical stroma, and it's the size that defines the sub stage. And in this case, we see a tumor that is between 2 and 4 centimeters. There is no parametrial invasion because there is an intact stromal ring. This means this is a stage 1B2. What is different to the previous classification is that now we have 3 substages, whereas in the previous subclassification, previous classification, there was only the differentiation between less or more than 4 centimeters of tumor size. So these 2 had been united in the previous classification. What was now the rationale for this new cutoff of 2 centimeters? First, it was treatment planning. We know that 2 centimeters is a critical tumor size for fertility sparing treatment, as well as for minimal invasive radical hysterectomy. Number two is also that we know from large pathological databases that the tumor of less than 2 centimeter is clearly associated with improved survival compared to larger tumors. And this is also true for the risk for parametrial involvement, lymph node metastasis, and depth of stromal involvement. And also the probability is low. Also, tumors less than 2 centimeter do have a risk of lymph node metastasis, but it's only 13% in sizes less than 2 centimeter. It's almost double of this in sizes 2 to 4. And in a woman with a tumor of larger than 4 centimeter and no parametrial invasion, there's already a chance of 44% of lymph node metastasis. So this is a woman, she's 33 years old. She has a wish for fertility sparing treatment. And here we do not see a tumor in the cervix at the side at this axis to assess the parametrium. We see a little defect of the conization here. And further down along the endocervical canal, there is no evidence of tumor. There's a little Nepothian cyst. This is the diffusion at the site of the conization. It shows a restricted diffusion or high signal on high B value, but in the ADC, we see it's bright, so there is no evidence of tumor. So is she a candidate for fertility sparing? Yes, she is. Why? Because what should we look for on MRI in these patients who wish to prefer to preserve fertility? We look for the tumor size. Either we see no tumor or the tumor is small, less than 2 centimeter in size. Histology also plays a role because it's best to have squamous cell cancer. Parametrial invasion has to be excluded, as well as lymph node involvement. This is done by imaging, but usually imaging is not enough. Laparoscopy is done in the majority of cases. And then we have to provide in our reports what is the distance between the upper margin of the tumor and the cervical os, as you see it here. And most surgeons also want to know what is the length of the uterus and the endocervical canal. So if we look here, again, this is the level of the internal os. Here's the tumor. She is a candidate for fertility saving treatment, whereas here is only a small tumor, but this is less than 1 centimeter, so she is no candidate. Let's now continue to stage 2. This is important because parametrial invasion is really a crucial decision factor for treatment planning. And if a patient has parametrial invasion or more advanced disease, then the treatment of choice is primary chemoradiotherapy. And this is taken from the really excellent paper of Evisala that I really encourage you to study, because there you can read all you need about treatment stratification. So in my clinical practice, I really often learn that it's difficult for radiologists to meet the correct criteria for a parametrial invasion. This is why I have summarized this. So in order to call a parametrial invasion, there has to be a disruption of the normal stromal ring, but there has to also to be a nodularity in the periphery. Or we see tumor nodules in the parametrium, or vessel encasements, like you see it here, or thickening of the uterosacral ligaments. As this is so important, I have here also summarized the critical findings and the essential of parametrial invasion. If we do not see a tumor and have a full stromal ring, we can exclude parametrial invasion. We can also exclude it if there is an intact stromal ring that's at least 3 millimeter. What's challenging is if there is no clear stromal ring seen, but the contours are smooth, then we should not call this parametrial invasion. This is a case of nodular contours, so there is parametrial invasion, but be aware we are quite good for the small tumor size, but we are limited in large tumors. So this is just an example. Here we see a tumor, it's 5.5 centimeter in length. There is parametrial invasion. There was no lymph nodes seen, so this is a stage FIGO 2B. Another case, there is a tumor seen in the cervix, but if we look at the parametria, there is no stromal low signal intensity ring shown, but the contours are smooth. Also on the diffusion weighted images, the contours are smooth. And according to FIGO, in case of dot, you should classify the lower stage. So this is not parametrial invasion, but this is stage 1B3, also no parametrial invasion. Another case, again, we see a tumor on the plane to assess the parametria. There is a nodular contour. If we are not sure, again, we should look at the diffusion weighted imaging. There's a little nodular contour, and here on diffusion imaging, we can appreciate this well. This is parametrial invasion. Now, let's continue with the more advanced stages. And here I want to address the involvement of the lymph nodes, because this is the new incorporated stage. And due to the growth pattern of cervical cancer, where the lymph nodes are usually first found in the pelvis and then in the retroperitoneum, we differentiate between stage 3C1 and stage 3C2. FIGO states that the lymph node status can be determined with imaging and or with pathology. However, we should record the method in our findings. So how do we measure lymph nodes and what are our imaging findings? These are the criteria we have been using for many, many years in gynecological imaging. So we use the morphological criteria like the contour, the size, the periphery, and also the enhancement. And particularly if there is necrosis, this is a sign for the presence of metastasis. DVI is used for better visualization, but there is discrepancy in the literature according for using ADC. So it's usually not used. Why is lymph node metastasis so important to incorporate in the staging? Because it has been well established that lymph node metastasis present a very strong prognostic indicator, and there is clearly this difference in terms of 5-year survival between patients that are lymph node negative and those that are lymph node positive. So I want to show you this case of a young woman who has a quite small tumor. It's 3.5 centimeter. There is no parametrial invasion, but what we can see that there is a lymph node with probably some central necrosis. It's well also seen here on diffusion weighted imaging. So this was a lymph node metastasis in the pelvis that was here also proven by PET-CT. And what does this mean for this patient? This is now stage 3C1, whereas in the previous classification, this was 1B1. But this means that her 5-year prognosis clearly deteriorates from 85 to 60%. So lymph node metastases are an important prognostic factor, but they are also an important determinator for treatment planning. And this is why American and European guidelines recommend PET-CT for stages larger than, in size 1B, larger than 4 centimeter. And here I want to show you a case where we had CT, MRI, and PET-CT. And this is the patient with this tumor that's clearly seen with MRI, but we can also appreciate that there is a tumor on the CT. The parametrial invasion is clearly seen on MRI. I would probably not call this on CT. Let us go to other images of the pelvis, and what we see is that there is bilateral lymphadenopathy in the pelvis. The MRI here is much better to differentiate between this metastasis and the normal ovaries. And in the pelvis, all these findings look quite similar. But regarding the retroperitoneum, in MRI, we see a lot of very tiny lymph nodes, but we would not have called them, according to our criteria, malignant. However, PET-CT showed that these were all FDG avid, and here the radiation portals had to be adapted. And this is one of the reasons that PET-CT is considered superior to CT and MRI, and it's important when it comes to treatment planning. Also, if you look at the data, PET-CT is also not ideal, but it is, at least up to now, the best imaging modality. Another case showing the superiority of PET-CT over MRI, a patient for radiotherapy planning because she has a large tumor. It's well seen on MRI, but what we did not call was this lymph node pathological, whereas in PET-CT there was clearly a very active PET pattern, and this was lymph node metastasis, and also this was important for treatment planning. Let's now continue and finish with the more advanced stages, and in terms of what do I get? So in terms of local invasion, it's important to assess stage 4A, but stage 4A is mucosal infiltration of the bladder. So this is again where MRI is helpful. It's helpful to exclude bladder wall invasion. If we look here, the bladder is well preserved. Whereas in this case, there is a tumor with percontinuation growth into the bladder. In this case, it's difficult because there is a broad contact. Is there invasion or not? And this is one case of a classical pitfall, that's bullous edema. So when we do not know, is there bladder invasion or not? What should we do? We should apply diffusion weighted imaging. Why? Because then if there is diffusion restriction, then we can call this bladder invasion, as in this case. And here the benefit of diffusion in this patient was that we did not only verify here the tumor invasion of the bladder, but there was also a bone metastasis. So this was already stage 4B. I want to show you more pictures of this lady. And actually, she was 30 years old and had come to the hospital because of pelvic pain and urinary loss. And notably, her gynecological examination 1 year previously was normal. But what we see is really an extensive tumor. Here we can debate if there is invasion of the bladder, but here clearly is tumor invading the bladder. The coronals show that there is an extensive tumor. There is lymphadenopathy encasing the normal ovaries. If we go to the pelvis, we see again the tumor, extensive lymphadenopathy seen here, and this was again also verified in PET-CT. due to the history that within 1 year there was a really large and advanced tumor, there was already suspicion that this is some aggressive type of tumor, and indeed it was neuroendocrine tumor of high grade. It was decided on the tumor board to provide her with systemic chemotherapy and radiotherapy. And actually, within 3 months, the tumor was completely gone. But unfortunately, but somehow to be expected, a little bit less than 1 year, there was again this tumor displaying by intermediate signal intensity in the cervix, and in the retroperitoneum, there was a mass seen, which could then be better displayed with contrast-enhanced imaging on the diffusion as extensive retroperitoneal tumor. And there was also peritoneal disease in this patient who after this quite soon died. If we have very advanced stages, this is often due to aggressive tumor histologies. And in this patient, there was a G3 adenocancer of the cervix. And what we did see is there was already peritoneal metastasis seen on the CT of the pelvis, where we see these tumor deposits. The tumor of the cervix was not that big, but there is clear abnormal finding in the cervix. And the contrast-enhanced series of the upper abdomen here showed and verified the findings of peritoneal spread. Here, additionally, staging CT confirmed peritoneal metastasis, but the value of this staging CT was that there was lymphadenopathy in the supraclavicular region to be diagnosed. And whenever we have such a finding, we know that this is associated with a very poor prognosis. And this brings me already to my last set of slides. I wanted to show you that the revised FIGO classification now acknowledges the central role of radiology in treatment planning. If available, and in our countries we have MRI, we should use MRI to assess the tumor size, perimetrial invasion, and invasion of adjacent organs. We can use MRI for the lymph nodes, but preferred technique in advanced stages, and particularly before radiotherapy, is PET-CT. And if we have already, from a clinical aspect, a very advanced disease, then we can also go for CT. And if you are interested in the details of imaging of cervical cancer, then I recommend you this quite recently published publication by the European Society of Urogenital Radiology, where me and Evis were also authors of these publications. And with this, I would like to thank you very much for your attention.